All right, we can go and get started. It is just past 12:15. So today's talk is on navigating the driving talk. So this is, as I like to say, the elephant in the room. So the objectives here, I do want to go over a few of the older driving statistics that we have. These are outdated, but pretty consistent. I've seen I just don't have the actual copies of the recent updates, but they're pretty similar. I do want to relate a little bit of neurobiology, just as far as like, when I'm discussing this with patients, especially when we're dealing with neurology disorders and specifically progressive degenerative neurology disorders, tying that neurobiology in for why we are concerned about driving is important. And then we'll talk about how some of those discussions can take place. It's oftentimes, I shouldn't say often, but sometimes we do have to pursue a formal evaluation. And what does that look like? What is a good evaluation? And then we'll talk about the last resort option. So yeah, this is actually one of the most difficult conversations we have, even as much as actually giving a diagnosis. It is important though. So this actually came up like in the state of California. There was initially if you were diagnosed with Alzheimer's disease at all, you really couldn't get a license anymore. So what happened is folks just stopped going to doctors with memory problems, right? And so there is this balance, right, of trying to maintain independence, but also understand what's going on, get a correct diagnosis, but then also realize when there is that time to retire from driving. And there's a good chunk of drivers who have cognitive impairment over age 80. Some numbers are somewhere between 20 to 30% have cognitive impairment, and then that number even skyrockets higher at 85. But not all individuals, especially with early Alzheimer's, are unsafe to drive, and so navigating that is what we have to think about. And this is a major quality of life issue, especially in America, right? So we talk about all these things that we recommend you do in order to keep your brain healthy, right? And that includes exercise and being socially active and volunteering. But then we say, right, that also don't drive to these things, right? And so there's this very clear issue of social isolation if you can't drive to the things that we're recommending you go to. From a statistical standpoint, so we all know about the early age driving issue. This is actually before your frontal lobes are fully connected, right? So this is motor vehicle crashes in sort of the teenage group here, and it's split between male and females. We see a similar spike in over age 70, basically. And then that is further shown when we view it in, the number of miles driven, right? So usually younger age folks are driving a lot more than our older age folks. So per 100 million miles traveled, there's a lot more fatal crashes in this basically 70 to 75 and older group. And we know that this is only going to become more of an issue, right, as our aging population increases. So by 2030, this number listed back from our 2011 census is going to almost double, to where there's going to be over, getting between 50 to 60 million drivers over age 70. And so just going based on the numbers we have, the expected involvement of total fatality crashes is going to jump as well, to where it's going to account for up to 40% of fatalities due to driving. And so the common thing that I get in the clinic when we have these discussions is, well, doc, I've never had an accident, right? And so I think that's obviously not the decision tree we want to make that decision in, right? It shouldn't be after we've had something happen. That's what we're trying to prevent here. Especially when we look at the percentage of fatality rates with accidents in our older drivers, there's a number of health conditions and frailty to consider. So there's multiple different scenarios we encounter, and you guys on the call, especially if you have seen patients and discussed this with them, right? There are lots of spectrums of concern here. So in our clinic, in the memory clinic, everyone has, well, 99% of people bring someone with them, right? Whether it's their spouse or one of the adult kids or some close family friend, right? There are cases where no one is concerned. Now, the patient is almost never concerned, right? At least, especially if there's sort of a lack of insight issue. But there may be scenarios where, yeah, the spouse rides with them all the time. There's no concern. Great. Maybe they're in a very small town, country roads. There really hasn't been any issues or concern. Sometimes there's denial, right? Or just unawareness. They never ride with this individual. So that's things you have to ask about. But then there are plenty of cases where everyone's concerned, the whole family's concerned, especially kids are concerned, right? But they can't be the bad guy, and that's honestly our role as the physician, right? To listen to what their concerns are, and then take that into account when we're having this discussion. There's plenty of red flag warning signs that I'll just even print out a list of them, and say, hey, if we're not concerned right now, I want you to at least look out for these things, right? And so if they're noticing that the individual is getting lost, especially in familiar areas more often, and a change, right? Some people are just never navigationally oriented. But if that's a change, that's a concern. Right where the memory structures are in the brain is where your place cells are, right? And then failure to obey traffic signs and signals, cutting off other drivers, straddling lanes, making wide turns, reacting slowly to the environment, using poor judgment or making poor decisions, more frontal lobe tasks, having troubles judging distances, more of back of the brain tasks, having near misses, getting honked at often. I guess that should be a geographical issue, right? I guess if you're in Boston, that's a different story. But having family members, this is one of the most pointed questions I can ask, right? Like, oh, the grandkids are not allowed to ride with you. Why not? Right? That's a big deal. That's a major red flag, right? And then having an accumulation of accidents, tickets. So there are, as we've kind of reviewed over the course of the year, right? There's lots of different neurodegenerative diseases, different causes of dementia. I sort of rank these in my order of concern, of posterior cortical atrophy being number one, which we'll talk about, Lewy body disease number two, frontotemporal three, more of what we see as typical Alzheimer's four, Parkinson's disease five, and then our young onset Alzheimer's disease folks as six. Obviously, disease stage trumps any specific syndrome, because as the disease progresses, a lot of these can start to blend together. And then sort of an aphasia variant of Alzheimer's being last there. However, because of lack of insight issues, that's a different order in rank of convincing someone that it's probably time to stop and retire from driving. So by far and away, frontotemporal dementia can be the hardest one, because there's often a complete lack of insight into symptoms in that disorder. If Alzheimer's disease, when the right hemisphere is involved, and just especially when there's behavioral symptoms associated with Alzheimer's, that can be difficult. If we focus a little bit on the neurobiology, right, and we think about, well, how does the brain work? The back of the brain being visual cortex and visual information processing, the front part of the brain being judgment, problem solving. These are obviously going to be important parts of driving. So in my posterior cortical atrophy patients, I'm going to hide this for my own purposes. We're getting the back of the brain involved, right? So this is just a glucose PET scan showing where things are more red or more severe problems using glucose, which indicates neurodegeneration and indicates where the problem is. The front part of the brain is not the issue here, right? It looks completely normal. It's the back part of the brain that's the problem here. In over 90% of posterior cortical atrophy cases, it's due to Alzheimer's disease. It's just that the protein that's implicated, tau, is depositing in the back part of the brain preferentially, and so that's causing these usual visual spatial symptoms. We can test this in the clinic. We can have patients try to read what letter do you see here, and they'll see all these little E's, but they might not be able to see the big A. So I kind of liken it to seeing the trees but not the forest, right? And so they're not able to process two things simultaneously. So that's what simultanagnosia means. So in a complex environment, sometimes you're dealing with multiple things while you're driving. They might only be able to pay attention to one little thing at a time, and that could be a major problem with driving. We do overlapping objects too. So are they able to see different objects within a complex environment? So this is a quick little test I can do in less than a minute if I'm concerned about that. What is the field of vision you need in the state of Kansas? Well, this is sort of more of your total peripheral, 107, 110 degrees, outwards, and then here's 60, 30, your central vision here. In the state of Kansas, you just need 20 degrees. So basically, you can't be legally blind in order to drive, which was unfortunately changed in 2014. Most guidelines are around 100 degrees. Our previous state requirement was 110. So that's obviously a concerning thing for me. Similar to posterior cortical atrophy, Lewy body disease also involves the back part of the brain. So we very commonly get visual spatial difficulties, but you can have Parkinson's symptoms as well, which might change processing speed and reaction time, which would also be difficult. Here's some examples of cubes and clocks from patients with Lewy body disease. And it's this back part of the brain problem, which is similar to that posterior cortical atrophy case I showed you. In frontotemporal dementia, the anatomy that we're dealing with in this is the frontal lobe primarily. And so, when we look at a glucose PET scan in this individual, it's really the front part of the brain. In this case, this was more of a behavioral variant where the right front part of the brain, even more than the left, was involved. And so what that can lead to is troubles in, judgment, cognitive flexibility, impulsiveness, poor decision-making, changes in processing speed and executive function, right? And, we've seen, there's been cases of road rage and impulsiveness decisions, right, associated with FTD. For the amnestic folks, which is really your typical Alzheimer's case, which you most commonly see in primary care and across non-specialty clinics, this is the most common way it presents. We're dealing with the short-term memory structures, which are the hippocampus, which I kind of circled here. This just shows you sort of a progression of Alzheimer's disease over probably a 10-year period, where these are more consistent with when we start to see symptoms. What else do these memory structures do, these hippocampus structures do? Well, they basically are where your map representations and place cells are. And that's why individuals can do relatively well in a very familiar local radius. Those neurons are still, they have a lot more cognitive reserve, right? Those neuron networks do than the less familiar maps. But that's sort of the pattern we see. Less familiar areas become difficult first, and then as the disease progresses, even local areas can become an issue. If individuals have used a GPS in the past, obviously they can't learn a new technique very well because of these short-term memory structures being implicated. But if they've used one in the past, they can still get around okay. If they can rely on the GPS instead of their place cells. But they will struggle with more novel and especially more complex environments. Or dysexecutive Alzheimer's disease. So this is what usually we see when someone presents under age 65 with Alzheimer's. So especially in the mid 50s and late 50s and early 60s, it's more of a parietal lobe problem. And then there's this big frontoparietal brain network that gets involved. And it actually tends to spare the hippocampus, at least for the first number of years that the symptoms are present. They're also highly reliant on the GPS, but for different reasons. It's really to offload mental processing. So these folks have extreme difficulties with working memory and with multitasking. So there literally just cannot be any distractions. They can't even listen to the radio. They can't be on the phone. They can't be talking with someone in the car. They just really have to focus on driving. And then if they have the GPS telling them where to go, then they can really just focus on that, right? And so we see some success with GPS reliance in these folks as well. For the language variants, things like logopenic aphasia, this is where really the language network is primarily affected. So the left hemisphere of the brain, this is basically overlapping the language network in this case. This is almost always due to Alzheimer's disease too. There's plenty of other aphasia cases that are due to frontotemporal disease, where the front part of the brain is more involved. But this one specifically is Alzheimer's. And The main concern here is just if their aphasia is severe enough, can they communicate? If there's an emergency, if they have an accident, that's usually when we start to get concerned more than any other cognitive issue. So it's usually later in the disease course where this becomes more of a problem. As far as things that should at least be in, if you see patient, especially in like a geriatrics clinic, almost always has these. If you're a primary care office that does see patients over age 65, having these available at least in the waiting room, if family's coming with the individual and they just don't even know how to start that conversation, these are really good tools, right, for families to have available to them, to introduce that discussion. In the clinic, when I'm seeing patients and they have clear cognitive impairment and we're kind of in this gray zone, or certainly if I'm more concerned about it from a visual spatial standpoint, there are different strategies, right, to get that point across, right? So I usually will use a shorthand in my note that talks about how there's not always just a clear-cut score of when it's time to stop, right? But we're talking about a disease that's progressive. There's going to become a time to stop. It's not a matter of if, but when. And so that retirement from driving, we want to obviously do before something happens, and we want to maximize independence, but as safely as possible. And so I'm usually, if I'm in that gray zone where it's not entirely clear if it's time to stop or retired from driving, then an on-the-road driving test is what we recommend at that point, right? From a liability standpoint, right, if there's been concern raised and they're in an accident with, not having gone through this process, then that can be an issue from a liability standpoint. And most will understand that. Or, sometimes it's from an altruistic perspective. Well, I don't want to hurt anyone else, right? But when there's lack of insight, that's usually not gonna be their approach. So the Alzheimer's Association does have this. I've seen some of our geriatrics colleagues use this, and I don't personally use it, but I like the idea of having a driving contract, right? You're diagnosed with a disease that we know is progressive, and while it might be safe to drive right now, that at some point that's going to change. And I understand this would be something obviously you get involved early on, when someone's able to kind of make that decision, and that thought process can take place. So what does a driving evaluation look like? So ideally in earlier stages, then we can be more proactive about their strategies for long-term success, both with driving, but also with when to retire from that. The goal is basically to still maintain that level of independence and mobility in the community, right? So a lot of times what happens, especially when we're in kind of mild cognitive impairment, really more mild dementia ranges, is there's at least a reduction in the amount of driving, right? The more local radius, the non sticking with daytime, sticking with non-highway type of driving, it's going to be a lot more hectic. And so, but sometimes these do end up, these evaluations end up in the retirement from driving discussion. So there is this website out there, the American Occupational Therapy Association, where it's basically a database of driving specialists. We happen to have one here in Kansas City, so we partner with this PAM Health Rehab Hospital of Overland Park, and they do a very thorough job, right? So what does a thorough evaluation look like, right? I mean, it includes a cognitive evaluation, includes visual testing, it includes processing speed and motor processing, and it also includes going on the road and driving with them, right? So oftentimes a virtual driving test is not adequate enough, especially when we're dealing with changes in the brain. Usually an on-the-road driving evaluation is necessary. From a in the state of Kansas, we are not a mandatory report state, but you certainly can report, right? It's one of those things where sometimes a physician or an optometrist will be asked to weigh in if the Department of the Division of Transportation has been at least alerted for someone that may be unsafe to drive. And anyone can do a letter of concern, right? So this could be a family member, this could be a neighbor, this could be law enforcement, right? If law enforcement pulled them over multiple times over the last few months, and also us in the medical community can do it. For some families, that lack of insight is just, there's going to be no way through talking about the liability, talking about the don't, there may just be I don't see any problem with my driving, so I'm going to keep driving, right? And so in those scenarios where it's really just unsafe, they may even had like 4 accidents, right? And they just don't, there's no insight there. That does happen. And so really then it just comes down to we've got to control the key access, right? So they just don't have access to it. Sometimes you can get a kill switch activate, basically where they can't activate the car with the normal key, right? There's another separate switch that someone can install. And other times, we did, with my grandfather, this is what we had to do, just basically get rid of the car, because every time he saw the car, it just brought back a memory of driving the car, and then we had the same conversation, right? And so it was literally a out of sight, out of mind situation where we just had to sell the vehicle. So I will go ahead and pause there, and then take a look at the chat. The only problem with getting rid of the controls is that I have to bring them back. Fine. I don't know if anyone can read the, because I can't see the chat until I get my controls back here.
Sure. It looks like we have a question in here. Who can implement a driving evaluation?
Who can implement one? What does that mean?
That's right.
Order one, or thank you. I mean, so usually your physicians are the ones that order them. Okay, here we go. I got it back now, so I can take a look at this. Yeah, so that's looking like it's coming from Dr. Quo. I mean, yeah, usually the physicians are who order the driving eval. We fill out it's a 1-page sheet, and we fax it over to the PAM folks, and they will call the patient to schedule it. And we see a good comment for the PAM Health. Yeah, and especially for post-stroke, that's a good point, Annie. Like obviously we're talking, I'm a neurodegenerative specialist for a memory clinic, so that's more of what we focus on this talk. But there are seizures, there's strokes, there's neuropathy, there's lots of actually different neurologic conditions where even sometimes they can get better, right? So then it's talking about, well, what are compensatory strategies while there's improvement? Sometimes there's rehab associated, right? So they do that rehab program as well. Yeah, so at KU we have a driving simulator as well. When you're dealing with neurodegenerative diseases, oftentimes what I see on those reports is recommend formal driving evaluation, right? So I think that if it's very clear that they shouldn't be driving, the virtual one can work quite well. But if you're in earlier stages, I found it to be kind of like a middleman of we're going to be doing the on-road driving evaluation anyways. So I've mostly just gone that route. But it is nice to do it virtually if you're pretty certain they shouldn't be driving, and then you don't want to have them on the road during a virtual one could work in that way. So some cars like Teslas have self-driving. Steve, I don't know how much I would trust that, right? There's lots of issues with the idea of self-driving right now, lawsuits and things. I think certainly it could be helpful if it was very good. Actually, a lot of the newer things on cars, as far as like detections of are you not in the lane appropriately, right? Beeping at you and things like that can really help keep people from having accidents, right? But I had one patient say, yeah, we got a new car, and then the thing just kept beeping at me until we figured out how to turn it off. And I was like, oh no. Right. So those things can help, but obviously only if they use them. Yeah. And so Shelly, thanks for noting that. That's a health systems problem, right? Actually, it doesn't make any sense why an auto insurance and a health insurance wouldn't come together to help pay for these, right? So if they're dealing with patients that are getting severely injured and using healthcare dollars, and the auto insurance, the cost of repairing vehicles, right? I mean, that should be a legislation issue. Contact your legislators, and I mean, this should be something that shouldn't be that controversial. Of we shouldn't be having to pay for these things, for out-of-pocket costs when these are absolutely necessary tests, and trying to determine who is still should be independent. And the problem with neurodegenerative diseases, right, is so Annie, for that case of like a post-stroke, like you rehab and then you don't need to do it again, hopefully, right? But with neurodegenerative diseases, we might need a reevaluation in a year, right? And those are things that I hear the cost issue. I can guarantee you a $12,000 totaling your car and healthcare expenses is much more expensive. So that's one thing that I would say to the cost of the assessments, and that's partly why you want a good assessment if you're going to do it, right? And so that's why I recommend PAM. As Melissa, you can double check on that, but I would imagine the driving simulator would have a cost as well. But yeah, I think, I mean, that's a systems issue, right? Like, it doesn't make any sense why auto insurance and health insurance couldn't come together and help fund a $300 test, right? Especially if it's keeping everyone safer. Oh, and thanks. Yeah, so it looks like our next one, this will be, so Michelle Needens will be back on, and you guys will really like this one. So this is Michelle, and mostly Michelle, but together we kind of came up with this neuropsychiatric symptoms guidebook. So this is really addressing the behavioral symptoms that happen with dementia. We've had a talk on it in the past, but this is really more of a real world tool that you can use. It's available in a PDF form, but also in a sort of a clickable format. And so she'll go over that with you, and then we'll have obviously access to it for those that are interested in having the guidebook. Yeah, Steve, that's a good point. And we see it too, where patients will set off to somewhere and then they'll kind of forget where they were going, right? And so they'll sometimes that's when they're calling to see, because they're lost of where they were going. But they can sometimes just drive in a wandering state. Rosa, it's November 17th is when we'll do the next one. So that'll be in 3 weeks? 3 weeks. The reason I think we originally had the 10th, if you had an old schedule, but that's Veterans Day. So we were not here that day. So we'll do the 17th instead. Oh, Olivia, that's a good point too. Yeah. So if someone is not, like, let's say the patient lives alone, families from, maybe over 30 minutes away, they don't really have a great idea of how the driving is going. Are they getting lost? You can use, phone devices and AirTags and tracking devices, basically to just get an idea of, like, are they going where they say they're going? Are they really going all over the place? Sometimes we learn a lot with those, but then it brings some peace of mind that, yep, they're doing pretty well with their navigation and things like that. So that's another alternative to just keep track of how someone's doing. But obviously you only get so much with that. You get GPS level information, not like, Are they staying in the lanes? Are they having near misses? Those types of things that really would only come with riding with the individual. All right, we're past time. Thank you all for the comments and the interaction, and we'll see you, I guess, in 3 weeks then.